Okay, so we're going to enter the board meeting proper now. Just to say that this is being recorded and will be put out on the on our website. So it's a formal open board meeting where the public will see this. So have we got any declarations of interest for anything that's on the agenda, please? No? Good, that's fine. Liz, what apologies have we had for this meeting?
Just one apology, Neil Hayward, non-executive director.
Okay, and as I said in the closed board, that was because of our moving at fairly short notice the meeting by a week to give the execs more time, rightly so. So it was no fault of Neil that he wasn't able to be here today. So just before we hit the minutes, I want to extend the board's congratulations again, having had the closed board meeting, but congratulations to Andrea on her appointment as our chief nurse. And we're really pleased that you've got this appointment, Andrea, and we're looking forward very much to continuing to work with you closely going forward.
Thank you, Andy. I'm delighted, obviously, of being made substantive. It's a dream come true, so thanks ever so much.
Great, thank you. So we'll now move to the minutes of the last session on the 30th of July, and I'll go through them page by page to see if we've got any comments. So page 1. Page 2.
Yeah, I've got a comment, Andy.
Yeah.
Right at the bottom, it says Jane Dale, that paragraph. I'm just not sure that right at the end it says food would be another area for improvement, although it was noted that the dietitian team have provided tablets. Once aware of certain criteria, I don't know that they would provide tablets. I was more about adequate food. I don't know.
Yeah, I'm not sure about that. And does it mean tablets as in tablets you eat, or tablets for communication?
But also, it'd be unusual for dietitians to be giving tablets.
Yes, I just
thought that was a bit incorrect.
Okay, well, we've got the recording of that, so I'll ask Liz and Sal to go back to the recording and just check what was actually said. Thank you.
Thank you.
Page 3. Okay, page 4. Okay, page 5. Page 6. Page 7. And page 8. 9. 10. 11. Only 7 to go. 12. Page 13. 14. 15. And 16. 17. On to questions from the public there. And finally, 18. Okay, so with that one check that we're going to do against the recording, can we agree those minutes, please? Yeah. Okay, thank you. And we go to the log. There's no open actions. There's actions due at a future meeting. The others are down as complete or closed. So unless anybody has any points on that log, I shall move on. And I'll move on to my report. I'll take that as read, and I'll just look at some of the things that really are in the executive summary. Well, first of all, to say, you know, I'll log it now, my official thanks to the governors for offering and me accepting another 3 years as chairman. I was absolutely delighted to do that, and I really look forward to working with you all again going forward. You know, it's been a real focus over the last few months on the recovery of services and getting ready for the recovery of services and actioning that and our North Star objective. And I'll leave others to actually describe that, the progress. But I've been really impressed by just the sheer amount of effort that's gone in there. COVID, of course, was quieter over the summer, but it's an enormous effort, much more difficult to turn things on than to turn things off, I think we found. I just wanted to mention the recent recruitment rounds. I think both for non-executives and consultants, we've had some fantastic fields, and I should now add chief nurse as well, by the way, that we've had some fantastic fields and some great candidates. And I think we're attracting the right sort of candidates. And interesting, when we're talking to them, they're saying about reputation. And you know, the paediatricians that we had recently were just fantastic candidates, and the non-executive directors and the chief nurse. So I think that's testament to all of you, really, and all the teams for getting the right things out there. I wanted to highlight the virtual listening event that was organised by our own Sue Wales for North West Surrey. I thought I joined that. I know several board members were on that. The breakout groups worked, and it was amazing to see the range of voluntary, community, faith, health, social care groups that were on there. And the big learning for me was nobody knew what was out there. Nobody knew the breadth of services that all these charities and faith groups and everybody else actually offered, and the need to have some sort of directory of services so that we know in our own area and that people can say, talk to them. So, but I thought it was exactly the sort of event that was needed to accelerate our anchor institution work. And so long as we build on that. And a final thing, just David and I co-signed a letter to all staff, thanking them for all their work and indeed offering them a well-being day, an extra day. And I have been absolutely struck by the impact of that. As David rightly said, there's been nobody coming back saying, but. And I just got, when I went for a coffee between the two board meetings, again, I got stopped by one of the ex-OCS staff saying, thank you so much for the letter and for the day off. And, you know, so, and that's not the first person, that's probably the 10th or 12th person that stopped me in the corridors over the past week or so, saying that. So I think it was a good gesture and the right one to make. So I've got a question from Marcine and then Andrew.
Thanks, Andy. I'm echoing. Is it a problem?
Go on, Marcine, you're right.
Okay, so mine was about the Wellbeing Day, which I agree totally deserved. 2 points really. Is there kind of a national initiative? So just like the story about visiting and differences between trusts, is this common? And secondly, is this being funded as part of the extra COVID funding? I just like to know those 2 points. Thanks.
Thank you. I'll ask David to respond on that.
Yeah, so in the first bit, I mean, it was brought up at one of the system meetings saying we wish you'd discuss this with us before we'd launched it. So it's a good point, and in fact, I took that on the chin. I think that was a really good point, that we should have had that discussion with them. I think that we were very much looking at our staff and everything, and I suppose that we were just a bit more too inward focusing at that time. In terms of the funding, I mean, Simon I think the fact of the matter is we won't know. We have put this in the COVID funding pot, but it's clearly identified, and it may or may not be agreed. And you're right, it was in consideration. But I think, as Andy says, the feedback has been extraordinary, really. So I'd still do it again.
Yeah, thank you. So Andrew.
Yes, just to say, Andy, I agree with you. I thought the listening event was really good, and I thought Sue and colleagues did a really great job, and we found it really interesting as well, North Enterprises, to engage with all of that. Just so the board understand, we've had very good conversations with Tom and Jack Wagstaff at the ICP and others, and the voluntary sector increasingly about a new business model around all of that, because these traditional models, which are all very grant dependent and create all sorts of unintended consequences, need to be really examined. And the exciting thing is, we are starting to do that, and we've developed together a paper called Health is Everybody's Business, which starts to think more entrepreneurially about how do the public sector, the private sector, the voluntary and social enterprise sector actually work together, and how do you think about money in a different kind of way. And Tom and I and Jack and other colleagues across the system actually are now getting into quite interesting, the early days of interesting conversations about money and about procurement. I mean, the hospital itself is a massive organization, but how actually does it procure services? And how does that lead to jobs and skills and opportunities around it? And so just to share with you that the listening event is leading to some very interesting conversations that are seriously about money, transformation, culture, all of those things. All these things we're talking about today are connected, and I think this is a bit of it that I think has national significance, and it's very interesting how quickly that's happening actually with Jack and Tom and other colleagues, and particularly the social sector and some of the churches. Actually, I've had some really interesting conversations with some of the church leaders of what is the role of the church in a post-COVID Brexit era, and maybe they have to move on also from what I call 1970s culture into a more entrepreneurial culture. So I just alert the board to the point that these very interesting things are going on, and Tom and colleagues have been really good on that whole conversation. It's how we join the dots with the hospital.
Thank you, Andrew. Mike, did I see you had your hand up at one point?
Yeah, yes, I did, Andy. I don't know how much it's worth. I mean, you asked the question about what other trusts are doing. So Frimley have lots of discussion on how we mark the staff contribution, medal campaigns, ribbons, memorials, etc. But with respect to the day off, Frimley have done that for quite some time, recognising birthdays as a day off for service, and I know it goes down very well. I think it's a splendid idea. So just not an obstacle.
Thank you. Thanks, Mike. Okay, any other questions on my report before we move on to David? No? Okay. Right, David, you're on.
Thank you. Well, I take the report as read, but I suppose what I'd like to first start off with adding my congratulations to Andrew's appointment. I mean, you've worked through an incredible time, and during this process, you didn't take your eye off the ball, even though you were going through this very rigorous process. So congratulations. It's going to be great working with you going forward. I'd also like to add my congratulations to Andy being reappointed for another 3 years. And I think in the other changes, I suppose that Suzanne is very much looking forward to coming back, and you can read her message about her experience in the NHS. I'd like to take my time saying this is it's been a privilege being the acting chief executive during this time, and I'd like to thank everyone in this room for the support and help they've given me, together with the support from the staff and the divisional teams and the community, and the wider system. So I've been very privileged to be in this position. So thank you very much. I would like to say a special thank you to Zach. Zach stepped up into the medical director role, and he's been an absolutely brilliant support during this time. So thank you very much for doing that, Zach. Most of my report is looking at COVID in various forms, and that's how we're coming out of this extraordinary time and how we're looking forward and trying to enable services and link in and go forward. And I suppose that when I was looking at this, I think there are really 3 areas that we need to be very clear about what our plans are about, and that's keeping the community safe. So we are trying to keep the community safe, and that's why we have to get our communications right about why, because we will be attracting patients who are ill and therefore will have transmissible infection, and why that is that we're putting various mechanisms in place to protect the transmission of that, visiting, but also we have to be mindful in the community about the other effects of this COVID pandemic. the economic prosperity that you talk about, Andrew, at great length, the isolation in the community and the mental health that's occurring there. So we mustn't just be very blindsided and just think this is just about an infectious disease. I think the other bits is that we do need to keep patients safe, and keeping patients safe is making sure that we look after them in a very safe environment that's got the right infrastructure, that we actually screen our patients in the right way, and that we protect them from transmission. And I think the other thing is we do have to keep our staff safe, and that's really, really important. I think in the first wave there was a huge amount of anxiety from changing advice about PPE. I think we've stabilized that now. I think the work that Louise's team has been doing in terms of the work-based assessments, the risk assessments, is an amazing amount of work that's been done, and it's really, really important. And I think also the work around getting the staff to reflect on what they've been through. This has been quite a traumatic time for lots of people, and actually giving them avenues to reflect on that and support going forward. Not passive support, but actually interventions that support people during this time. Because as we all know, that as we go forward, they are very tired. We're asking them to do much more work. And actually in our drive to look after the patients in the community, we can't just stop everything like we did last time. We've got to work out how we can deliver that. And I think that the other bit that's in this report, which I think is very germane to this, is really highlighted how we have to collaborate within the system to actually look after community staff and patients. The work in the ICP that's been going on is absolutely extraordinary, and I think it is gaining momentum. It's certainly gaining people who are understanding, rather than looking at us and saying, I don't know what you're talking about, they're actually engaging with that process. And actually, we've got some traction at the ICS level to say, actually, we've got to move a few tectonic plates around there to make some room for some of this other place-based working to work. So I think it's a really exciting time going forward. There is huge amounts that we have to do in the next stage, and it is a much more complicated stage. I suppose in the report, I've also just identified a few things. So Simon and his estates team, which is now Tom's team and everything, have just been doing the most extraordinary amount of infrastructure changes and building. And congratulations to Simon on his car park. It looks absolutely beautiful inside. We just need to make sure we get the landscaping on that front bit looking absolutely brilliant, and that mural painted, Simon, and it will be the star of the car park awards in some magazine, I'm sure. But that's not only what you've been working on. You've been building wards. You've been making things safer for everyone, and I think you've done an extraordinary job there. As well as that, you've throughout this whole time, you've managed to continue the digital strategy, and there's some people who've worked extremely hard on the digital strategy. Zach's taken on the chief safety role. Simon, you've been running the system thing. Fred Watson has been an incredible amount of work during those things and supporting it, because it's really important that this thing helps enable us going forward. And then the other bit that's coming is the catering side of things. So as you know, it's all changed in terms of the current field, and we will see different things happening. I think what we have to do is we have to get our staff feeding back to us, because this is really, we're testing things out at the moment. This isn't the finished article, and actually we won't get it right all the time. So we need to encourage people to feed back on how we're doing. I also, during this time, we did the Education Awards, which was an absolutely lovely thing that was done in the Postgraduate Centre, and everyone was really pleased to be recognised for their teaching during this time and before this time. So I think that covers most of what's in the report. I'm really happy to answer any questions. And anyway, thank you for everyone for your support during this time.
Thank you, David. And, you know, I think just on behalf of the whole board, thank you. I mean, I think we've had an extraordinary time, and thanks to NHS England poaching, you know, we've gone through the pandemic with, you know, an acting chief executive, an interim chief nurse, and an acting medical director. And I think we've done extraordinary things, and you've done extraordinary things. So I know Suzanne is back on Monday, David, but my personal thanks to you, as well as the board's thanks to for doing such a great job, and to you, Andrea, and you, Zach, as well. It's been really, really excellent. So, Merrick.
Yes, I mean, just to echo a couple of points that you said, David. I know in the board meetings, because we're seeking assurance, we we're giving some of these urgent big investments and other moves quite a challenging time. But to actually stand back from it, to actually be able to put together the complexity of these major programs, to find the resources that are limited in the country to actually put these facilities in place is really impressive, really impressive. These would be complex pieces of work if done in a year rather than in weeks. So I think it's a recognition, and thank you to everybody for that.
Yeah, I think also from the non-executive side, I mean, your support in all those things has been incredibly valuable. So thank you.
Thanks, Merrick. Anybody else? Any other questions on David's report? Thanks, David. A very, very clear and good report. Thank you for that. So we're going to move on now to the quality report, and I'm just going to ask Jane to kick it off, really, with the views of the Quality of Care Committee.
Thank you. Well, I'll assume, as always, that it's been read. The main areas of discussion were, as we've discussed in the closed board, we were concerned around some of the issues around the closure of serious incidents, and there have been some delays in that, but we've got a clear plan around that, and we have a timeline that they will be worked on and completed by the end of this financial year. We recognise some really good work in falls prevention, although we did notice a slight increase in falls in August, although they had been low harm. So we did seek some assurance around actions, and I'll ask Andrew to talk about that afterwards. We focused our activity on infection prevention, given our new North Star target and strategy. And we did recognise that we've made some progress, but we do have some challenges around surgical site infections, and that's going to be an area of focus, which the divisional directors were asked to look at when they actually presented their own individual reports. So we had some assurance around some actions have been taken with regard to some of the World Health Organization's initiatives to look at how we make sure that we take that forward and prevent that. And then we also talked about patient experience and the need to actually have a little bit more of a focus on that, so that we didn't just look at when we had complaints, but also looked at experience in the more of the round. And we now have Viewpoint, which will hopefully provide us with a lot richer information around the true experience of people when they come through our service. And we will look to focus more on this going forward in the committee, because we feel that's a really important area. We were very pleased finally just to see that the complaints performance has improved, and we're now well on target, because that did dip a little bit during COVID, but that has now been picked up, and that's excellent work. So that was a really positive thing to end on. I'm going to hand over to Andrea now if she's got any more comments.
Thanks, Jane. Andrea.
Thank you. Hopefully my connection's okay. It's just went a little bit wobbly there. So the key things I'd just like to pull out of the quality report is as follows, actually. So medication, we're performing favourably against the target that we've set, which is good to see. From an IPC perspective, again, we're on track with our targets, with the exception of that is around Klebsiella and MSSA bacteremia infections, but we are doing quite a bit of work around that with our new IV nurse that's now in post, and a big focus around the aseptic non-touch technique with staff to make sure that the line care is as it should be. So hopefully we should start to see a reduction in those areas. As Jane said, there's been some good progress on the SSI care bundles that have been implemented with regards to driving down the SSI, and it is a key focus. With regards to COVID, there was only, well, for July and August, 2 definitive cases of hospital-acquired COVID within the organisation, but I'm glad to say that there's no outbreaks reported amongst patients or staff, and I think that's down to the very strict controls that we have maintained coming out of the first wave, and whilst we've been in the lull before the second wave, we haven't really relaxed much, and I think that's clearly paid off for us with regards to our low transmission rates that we've seen in comparison to other trusts who have been having outbreaks. It still presents a clear challenge, but I think that's it's good to see that. From a deaths perspective, again, the numbers actually compared to what we've seen previously are low, 80 in July and 85 in August, and actually within the paper you'll see that our COVID mortality very much follows a similar trend to the national piece over a 6-week period. I'll just quickly touch upon harms, and just to say you will see in the paper about the pressure damage had increased actually. Now we do have our harms-free care team in place, and they've been doing quite a lot of work around this, and actually we're about to reinvigorate what we did have our 100-day pressure free care campaign, so celebrating wards that hadn't had an incidence of pressure damage for 100 days, and making a big deal of that. We did that before COVID, but had paused it during COVID, so we're reinvigorating that now, and I'm glad to say we've got 4 wards already. We're very close to meeting that target, which is fabulous. And actually we're instigating a 30-day piece as well, just to reinvigorate it even further. Falls, as Jane said, we've seen a reduction. The falls nurse is now back in the trust. She was self-isolating, so that's a really good to see. And obviously the Bay Watch piece that we've been doing has really helped with the falls reduction. And it was Falls Awareness Week last week too. So there was lots of pledges that you might have seen on Aspire from different staff members, myself included, which was good. The only thing I'll bring out about complaints is I know the performance thankfully has gone back up, but the themes that came out, and there's 2 key themes actually. One's around appointments being changed, and obviously we flipped to virtual appointments, but there has been some poor patient experiences around patients attending hospital, attending the organisation, thinking they had a face-to-face, when actually it turns out that it was a virtual appointment, and therefore having then to go home and obviously making the travel into the organisation. I was just reflecting on that actually with the DNA conversation we had in the closed board, and it would be good to maybe get a bit more granularity about how many of those that we're seeing and whether or not that's will have contributed to the DNA piece, because actually those individuals didn't attend appointment in the end. So we'll do a little bit of looking into that actually on the back of that conversation. And then the other theme was communication with relatives, obviously down to our very restricted visiting that we've got in place. We have seen an increase in complaints and concerns coming from relatives that they're not getting updated about their loved ones in the time that they would like whilst they're in our care. So we're addressing that as well. And I'll mention the SIs. We've had 6, but during July and August, but one in particular to bring out, which again, Zach, you can comment on, is about the BSPS piece. Just for open board, just to mention obviously about the 2 incidents around that, if that would be okay. So I'll just hand over to Zach.
Yeah, as I mentioned in closed board, this was regarding the labelling of results within the laboratory on cytology samples for HPV, human papillomavirus testing, and it affected 150 samples. And it was a lab-based issue, both in personnel and in the equipment that we use. There has been a recall of those 150 patients. They are not patients that are under our care. They're not in our area, but they span across the southeast because we are the central laboratory for that work. We have handled it, I think, pretty quickly and well, in that all the patients have been contacted. They have had a recall organised 2 months hence from their first appointment for first index issue, which was back in July. And we are potentially looking at an IT solution to make this problem a historical one. I think that's it. But if anyone has any questions, please go ahead and ask.
Thanks, Zach. Jane.
Just as I discussed in closed board, that we had a full report in further detail from a representative from BSPS, and we were very assured that the issue in relation to the errors made in the labelling had been picked up very quickly and had been managed very proactively in a collaborative way. So actually, we just obviously have to make sure that the patients are recalled, and that's taken forward over the required timescale. But from a process point of view, we were assured in committee that this has been managed very quickly.
Thank you, Jane. Any other questions for Zach or Andrea? Just one from me, just a comment first. On the executive summary, keeping in mind these are open board papers and that lay people will be reading them, could we just make sure things are spelt out on first thing? So must was in there, which actually in the main report is spelt out, but not in there. Things like VTE, you know, that just aren't. We do want the public to be able to see these and kind of understand. So that's
absolutely.
And the question was around the water safety. I think the footballers amongst us might be a bit worried about removal of dead legs, but I was just wondering kind of the progress that we've made, and is there still an ongoing issue?
So, I mean, Simon probably wants to come in. All I would say, there's been lots of progress done on this from, and a big sort of shout out to the estates team and Andrew Henny in particular for all the work that he's been doing across both sites, both Ashford and St. Peter's, to a point where you're absolutely right. It had been a concern with the levels of Legionella that we were picking up, but the controls that have been put in place by the team now have really reduced that risk significantly. So, well done to them. And Simon, is there anything you want to add to that?
Yeah, I'd just say we've got a lot of mitigations in place, like filters on the end of taps. So we haven't necessarily sorted the underlying problem in every case as yet. So there's quite a lot of background investment that's going on. It will probably go on for 2 or 3 years, to be honest, before that's fully resolved. But the risk itself is mitigated. So yeah, it's a long-term project, this, that we're moving heaven and earth to make sure it's fully addressed.
And I know, Simon, we've been speaking about Ashford and St. Peter's on that, but what about Woking?
Yeah, indeed, it's kind of issues wherever we practice. So even, obviously we function in Woking, but with BMI, with the Nuffield, there's issues at a variety of sites to different levels. So we're making sure all of those are tackled and ultimately our patients are safe and secure.
Okay, thank you. David?
I was just going to make a comment. One comment really is that, I mean, the quality report has expanded and expanded over time, and actually, we're going to have to expand the water section and the air quality section because it goes on. I just wondered, in terms of Andrea, with our North Star objective, which is transmissible infections, whether we are monitoring all the things that we should be monitoring. So things like hospital-acquired pneumonia, and actually, as part of the and there'll be a discussion, I think, at the BAF about the key performance indicators. And I suppose that we just need to review: have we got those right things that we are demonstrating? Are we being effective in our delivery of these things? It's the same with the surgical site infections, that we've done lots of really brilliant work in terms of processes, but we've got to look at the effectiveness now and whether that's in train.
Yeah, no, agreed, David. Absolutely, we can certainly move that forward.
Oh, okay. It's a historic hand.
Can I just mention one other piece, actually, before we finish, if that's all right, Andy? It was just to mention about the Infection Prevention Control Board Assurance Framework that was issued by NHSI and E for all trusts to do back in June, actually, to do a gap analysis against some 10 standards that they're expecting us to have in place from an IPC perspective. To ensure that our organisation is as safe as possible for both our patients and staff. And I have to say, the gap analysis we've done, which has been fed back up to region now, we're doing really well against that framework. And the only gap really that we've we've highlighted was out of dated policies with around infection prevention control, which we're addressing. So I think it comes back to the controls that we've had in place from an IPC perspective, our new operating model that we've had in place, our IPC strategy that we've developed has enabled us to report favourably against this framework.
Okay, thank you. Jane, is that hand back up again now? Oh, just checking.
Yeah, thank you. It's just to add on to Andrea's point, because I was going to raise that in the minutes, but absolutely, the assurance framework is now going to be a regular part of the committee for assurance to make sure that we are addressing any gaps. And secondly, to say that we did recognise when we were looking at our key performance indicators for the quality committee that we needed to recognise our aim to reduce and then eradicate healthcare associated infections as part of our key performance indicators going forward for the quality committee. So we will be monitoring progress but on both the assurance framework and in our key performance indicators going forward.
Okay, thank you, Jane. And thank you, Andrea and Zach, for a good report. Thank you.
Thank you.
Jane, I think you're on with the quality of care minutes.
Yes, they're really obviously as they were minutes from July. We've had a meeting since then, so these were approved at the last committee on the 24th of September. I have nothing specific to raise on those unless there are any questions. I'd just like to assure the board that at the recent meeting we again looked at the board assurance framework for infection prevention control. We looked at our key performance indicators and we agreed that that I have been appointed as the non-executive safety champion for maternity, which will help to give a bigger focus on safety within the maternity division, which I think is a really positive move forward. If there are any questions, then I'd be very happy to answer any on the minutes.
Okay, thanks, Jane. Any questions on those minutes? And as I think we mentioned earlier on the staff story, they're really welcoming you having that role, Jane. So that's super on the maternity side. Thank you. So we're going to move on to the next section, which is the performance section. And James, you're going to present the highlights from the performance report.
Yes, thank you, Chairman. So in terms of urgent care, we had a challenge in August, and you can see that from the figures. However, it's worth bearing in mind that when you look through the report, our challenge was we actually improved in the national rankings during that time, despite a decline in our performance, which is representative of the challenge that the urgent care systems across all of our hospitals are facing. So it was a bit of a mixed bag. However, since that point, we've put in a lot of actions to improve urgent care performance. During September, we have improved significantly on that. So we're back to the high 80s again for the type 3 and 92 for the NHSI. So we have brought more beds back online. That was our issue. It was two issues really. One was around beds. And when we initially socially distanced our beds, we went full out, and actually we've been able to understand that and bring back some of those beds in a safe way. So that was one of the impacts that we had. And the other thing during that time was we were running very segregated ED departments, a completely green and a completely blue, or whatever you want to look at them. But there were separate departments effectively in one space. And that meant that we couldn't run some of the functions in ED that we wanted to, and it was very difficult to, we would usually, and it was very difficult to run those under pressure. So we've managed to come up with a different way of doing things now, which has helped us improve performance and reintroduce things like our clinical decision-making unit back into the department, which is making a difference to performance. So in terms of urgent care, challenge in August, but that has improved subsequently during September. So a good level of confidence that we have made an improvement, and we are continuing to do so. In terms of elective care, I mean, much of the meeting already we've discussed around service restoration and the challenges of doing that. In terms of elective work, we have had some challenges. We have set out to really optimise our Ashford site. So we haven't just turned things back on, but we've looked at doing things in a different way. and that takes longer than just rebooking where we left off. So that's been a challenge. We've had some theatres down due to planned maintenance, and during July we had theatres down due to unplanned maintenance as well. So that was that's been an issue for us, but we're through that now. We're looking at some improved measures. We've got the works underway to refurbish 2 theatres and provide an additional new theatre at Ashford. We've got the 2 mobile theatres coming online. So we do have plans in place around elective work. Now the challenge will be going forward. We need 3 things to do elective work. We need theatres, which we've talked about. I've just mentioned the challenge we have had and the actions we're taking forward. We need beds, and that continues to be a challenge. We've discussed that earlier today, but we need beds on both sites to do our elective work on one site. So that is a challenge, and we need staff. Now, if we go back into needing to move resources around to support a COVID surge, then that will affect us again. But they're the 3 things we need. So we have a challenge on beds at the moment, as we know, and that's something that I'm working with the operational and clinical teams on resolving quickly, and we have some options to do that. So that sort of some assurance around electives, and we do have plans in terms of outpatients, which is the other side of that. We have again taken a different action, which is to move things to Ashford. So we haven't just started booking to the old clinics again, Ashford and Woking, but we are back up to around 83%. We're back to pre-COVID levels in August. We're back to sort of around 90, in excess of 90 in most specialties now in September. So some really good safe introduction of services that we should be reassured about. In terms of diagnostics, they have continued to improve, and diagnostics has really been somewhere where we can take assurance from. We have had additional CT scanner in at Ashford as part of the the national allocation for the Nightingale hospitals. We've got one of those, so that has helped us. So our CT is currently running at I can't remember what it is, 109 point something % of pre-COVID activity. So that's really good, and our MRI and ultrasound are broadly at 100%. So in terms of diagnostics, sorry, something's happening on the news. In terms of diagnostics, that is strong. So strong level of assurance there. And also in terms of endoscopy, that has been something that I've been raising at trust board meetings now for probably a year, if not 18 months, around the issue of capacity being outstripped by demand. So we do have confidence in our plan. It is a good plan. So we have a high degree of confidence about the plan that we have. We have been successful in securing 2 mobile facilities to come online this month. We have been successful in our work of outsourcing to Chobham and to the Royal Surrey County Hospital, helping us out 1 day a week. And we do have our in-house endoscopy services running through the weekends, and we have our urology centre opened up as an endoscopy room at weekends. So with all those actions in place and working, we have a high level of confidence now that we will be able to return our endoscopy to the levels of waiting times that we need to, and that we can meet demand. So there's some good news in there. And I guess the final thing from the performance report is just around cancer. And the board should take reassurance from the fact that whilst our number of patients over 104 days, which is a marker, it's a safety net that we have, because we only look at the waiting time of patients when their pathways end. So this is just looking at how many patients are waiting still. So a number of patients waiting over 104 days was up to 173, which is unheard of in this organisation. However, that was because of all the restrictions around COVID, but we simply couldn't do these cases. They were all clinically reviewed, and it was a clinical decision not to do them. But we are now down to 59 in this report, and it's continued to reduce. So the board should take assurance that we are managing patients in clinical priority order. And although we are not back to 100% of pre-COVID elective activity, we are looking after the patients with most need.
Thank you, James. Questions for James? Stunned into silence, James.
Yeah, good. Yeah.
Simon.
James, you talked a lot about our own capacity and performance and ramping up elective activity, but I guess we're also dependent on the wider systems. Did you have any view on how the system as a whole is is moving forward yet? Or is it too early?
It is a bit early. So in terms of diagnostics and other things in the system, they've come up. Our referrals aren't coming back up. They're not quite up to pre-COVID levels. So we know for routine that we're not quite there yet in terms of pre-COVID activity, and we are mapping what we think is our unmet demand through that time. So we're sort of trying to be a heads up of what might come to us. In terms of urgent care and things, we are working with people on discharge and flow through the system, but there remains to be challenges at the moment.
Okay, thank you.
Okay, David?
I suppose that in the interactions that I've had at the kind of ICS level, so particularly on the elective work activity, I mean, they are the other organisations are posting confidence that they're going to meet their trajectory, so we meet it at system level. But as James, I suspect you were just couching that in that all those projections are based on that actually COVID doesn't put people off course, and obviously we haven't been involved in working out how robust some of the calculations have been. I'm pretty certain, are you, James, that Royal Surrey is going to deliver what they've said. They seem to be coping with their elective workload.
Yeah, that's right, David. I think all organisations have unique challenges, of course, and some organisations are physically configured in a way that's enabled them to turn on services much faster. And I know organisations who have declared that they haven't had to socially distance a single bed in their organisation, where others are looking at a reduction of 20% bed stock. So it's variable across organisations and neighbours, but the Royal Surrey do seem to be in a strong position.
Okay, Mike?
Chairman, just to reassure you that James got well exercised at the committee and we asked lots of questions, but if I may, and there's a moment, could I ask for two comments? One relates to length of stay that we've already discussed in the closed board, and we're seeing an increased number of stranded patients, an increased number of people admitted. I wonder if discharge to nursing homes, which of course is such a national issue, is still problematic, and in being allowed to do that, whether that's placing restrictions on the system and speed of transfer. That's the first question. And the second question relates to backlog. And you did answer this question, James, but you didn't bring it up in your summary. I'm very encouraged by the change in criteria for endoscopy, which means that endoscopy may not be such a challenge for us. I just wondered whether you'd like to comment on that.
Yeah, so in terms of the first question, Andrew is leading on the discharge side of things and a bit closer to some of the detail in terms of the care homes. However, we are having some challenge. There has been challenge. I think things have improved significantly. But Andrew, do you want to comment at all?
So it's a good point, Mike. Actually, I mean, it links in with the discharge to assess model and the new discharge to assess model that was put in place with COVID and is now remains actually and is the model going forward, which is pretty much if there are any medically fit patients that we have in the organisation and need onward care, they are to be discharged from the acute within 4 hours. And we've never really, with our system partners, we've never really met that during COVID. It's improved dramatically from from days to a day, but it's still not where it needs to be. And I think it's fair to say that there are issues around adult social care and capacity actually that we're seeing, which they've got some huge challenges out there, which very much has an influence on nursing home and residential home placements. And so we're finding ourselves having to step down patients more now to our community provider in order as a step on really to those areas. But it is presenting a challenge for us, and we're having to work through it with the system.
Because I mean, it is a potential issue, isn't it? Because already the narrative is looking at why it got to nursing home previously, etc., and we were very clear about us following national directives, but I'm not so clear about the requirement for COVID testing now before onward transfer. Is there any clarity?
Yes. Oh, yes. Yeah, we've got a rigorous process in place for COVID testing before. Yeah. And in fact, the homes won't accept a patient until they know the status, and we have a dialogue with them to talk through that. So, yeah, I can absolutely give assurance around that.
And how long does that take? I mean, to the question of length of stay, it's edging up by fractions of a day. Is it 2 days to test people to discharge? You know, and how proximal to discharge does it need to be? I mean, you don't need to answer, but clearly it's a bit of an issue it's impacting on our effective use of capacity.
Yeah. I won't. Zach, do you want to come in?
Yeah, can I come in on that? In terms of pre-discharge, all patients just before discharge, within 24 hours, will have a COVID test, and that needs to be result back clearly negative before transfer. To answer your more broad question about working on the backlog, and in particular endoscopy, there are system and network discussions that have taken place, and changes in practice, particularly with FIT testing in the colorectal sector, that has meant that quite a lot of patients that we'd normally have tracked through the endoscopy suite are triaged out, and that has created some room and an improvement in the backlog figures. So there are changes in our triage systems, I believe, over the past few months, after detailed discussions, that will have an impact, a positive impact on our backlog as well.
Okay, David.
Yeah, Mike, I think you bring up two really important points, which are where we need to learn from what went on in COVID. And I suppose what we've been doing is myself and Andrea need to go through a report that our teams have produced, which is looking at the transfer into the nursing homes, and actually I think learn from that during that time. So I think that's a really good point to work out, you know, what happened then and what are we doing now, and is that safe? The second bit, I think, which there hasn't been so much focus on, is during COVID and getting people home, and social services and the way the funding flowed then and the way patients moved seemed to be the right thing to do for many reasons. But I think what people haven't done the analysis of, actually, not only was it probably the right thing to do, it was probably a very cost-effective thing to do as well. And that financial analysis on putting the funding in the right place to actually deliver to the patients what they need, rather than them languishing in the wrong place. I think we do need to make sure we don't lose that as we go forward, because it's all those barriers are going up just slightly, I think, in the system.
Okay, Andrew. You're on mute, Andrew.
Just so yeah. We've been doing some work with Louise, and Matt Warden, who you'll remember is the One North Enterprises artist who did all those drawings we showed you some months ago, has been spending time drilling into what's happening on the internals in the hospital and what people's experience has actually been. And it's really interesting to listen to people in the system. And we found a person called Sean, actually, who was in charge of A380s, actually, lots of the cabin crew that look after 500 people when you're on an aeroplane. So the private sector has paid him a great deal of money, actually, to become a top person in that area. And he found himself getting COVID and ending up at ASPH, coming back from Brazil suddenly, and being 4 weeks on a ventilator and all the rest of it, and is still in hospital and connection. So we've had a very interesting conversation as a person who's real expert on customer care and what it looks like. And he's very complimentary of the hospital. So be clear of all of this. He's amazing actually what's happened, but he has some really interesting insights as what he's seeing from a person who has to deal with difficult people on aeroplanes and food and all the rest of it, and the interface with some of your nurses and all of that stuff, which we've drawn a drawing about. So at some point, maybe not today, we might just share you that, because simple little things actually that cost nothing actually might really help you think about customer care and customer service if we're going to have now another phase of all of this, of what that means. And I'm happy to share that with you, with Matt, and take you through some of those points and learnings, actually, if that's helpful.
Andrew, I'm assuming he's given permission, has he? Given we're in
No,
open
no,
board.
he is. He is. He's become a bit of our eyes and ears. Actually, we've got a real engagement with him. He's a very interesting, experienced guy who thought his life was over. Actually, to be honest.
Okay.
At 63. Yeah.
And Andy, he's also the patient whose story we wrote in the letter when we wrote and thanked our staff.
That's right.
Okay,
So,
no, that's fine.
And he gave us a permission to use his story for that purpose as well.
Okay, thanks. I was just doing belt and braces.
Yeah.
I've got two questions. One is it right that one of the two endoscopy mobiles that we've ordered is now delayed, James? Or
yeah, yes. Simon, do you want to?
Yeah, so two things are happening. So the first one will arrive in November, but it will run 3 session days, and the second one will arrive in January and again do 3 session days. So we'll end up the year doing the same amount of work, but our trajectory has changed quite considerably within that. It's the pressure on all of these units around the system, so things ebb and flow on these kind of changes. It does affect our short-term trajectory, obviously, because of the not having 4 sessions as quickly as we would want, but we will catch up.
Did they not assure us on their availability when we placed the order?
Sorry, I'm playing with my mute button there. Yes, they did, but then we had a problem with the middle bit of the unit, which is essentially, I don't know what you call it, the recovery area. So we had both theatres available, but didn't have the third part of that. So it's kind of those sort of problems, Andy, I'm afraid, but it is what it is.
Are we talking two different things here? Because you talked theatres there. I thought I was talking endoscopy.
Both the endoscopies and the theatres have a kind of recovery area in the middle of those. So we've had problems across all fronts on that for one bit of kit or another in the middle of all of it. So broadly, though, their guarantee to us was to do enough work, particularly on the endoscopy, which was it's a managed service rather than just a hire of facilities sort of contract. So we've slipped a bit, but we should make that up.
Okay, thank you. Zach?
Yeah, and that's that gap that's been created because of the delay is being bridged by extended use of the Cobham and the work at the Royal Surrey. So we will still be we're very hopeful about our trajectory.
Okay. The other one was triggered by the Today programme this morning, really, which was talking about staff testing. And I'm just wondering where we are on staff testing. Jeremy Hunt was kind of making the point that, weekly staff testing and where are we on staff testing?
Okay, can I come in on this? We've had a group, a task and finish group set up around 3 weeks ago on this very topic. So our plan is on the 14th of October to begin a pilot, 50 staff members working on the Ashford site, which we recognise as the most important to keep as green as possible. Following success with that pilot, in 2 weeks, we'll extend that and roll it out across both sites, but again, focusing on our Ashford cohort of workers. Essentially, the aim is to weekly test people so that we have an assurance of the asymptomatic screen negative groups that can continue to work. There is a lot of behind the scenes work that needs to be put in place to have a successful program, because it clearly will involve vast numbers on a weekly basis. The laboratory are confident that they can cope with that testing strategy, but clearly we need to test the system out first, and hence this pilot first and then the rollout in stages. So, certainly by December, I would hope that we have a regular program of all staff testing, and that could be of the order of about 3,500 staff.
Okay, Jane.
Thank you. Zach, is maybe just me not understanding. When you say 50, is that 50 staff that will be doing the test or 50 staff that will be tested?
It's 50 staff that will be tested, and we will test whether the system of results, etc., works.
Okay. Okay. Thank you.
So it's a pilot. Thank you for that. That's very, very helpful.
I think we've also got to bear in mind that the same people that are doing the testing in terms of people like occupational health are also now embarking on our flu vaccine campaign. So
yeah,
it's also about understanding what resources we've got and how we deploy them most effectively.
We are potentially looking at ways of allowing staff to test themselves, which will reduce obviously the burden on the OH department.
okay, thank you. Marcine.
Thanks, Andy. Louise and Zach, have you thought about combining the two so that you had those turning up for the test having their flu jab? Seems to be an effective way and an efficient way to kill two birds with one stone.
You're very distorted, Marcine, on your verbal. I think we got it though, didn't we?
Yeah.
I'll hang up and start again.
Clearly, flu vaccine is just a one-off episode, but this staff testing program is on a weekly rolling basis. So although we may capture them once, going forward, it will have to be weekly. Sorry, does that make sense?
No.
It's difficult. We've great difficulty hearing you, Marcine.
I'll hang up.
Okay, thanks. Okay, we'll move on, and we can take Marcine's question afterwards when she comes back, because clearly not there. Merrick, you've got a lot of Modern Healthcare Committee minutes.
Yes, I mean, I covered them actually in one group, and I touched on it a little earlier. It has been a surprisingly busy, quiet period, normally in the August board. I think the two things I really want to mention about all of this short-ordered capacity to meet, as we know, the backlog of work, and to also help with elective surgery in our clean site. The key thing is, have we assured ourselves of the decisions that have been taken, that were taken as best they could be, but I think particularly for the modern hospital, also the funding. So in terms of the decisions, we have really gone through a lot of detail here, and in fact asked for one of them to come back to us again, because at first pass we didn't have everything we needed, not because there was fundamentally a failing in the work done. It was a failing simply of time, not enough time to really be able to answer all the questions in first pass. With regard to the funding, most of this has effectively been procured in the context of, within Surrey Heartlands, an understanding that it will put on our OPEX outside of our envelope, and we have sought and got assurances on most but not all of the funding that we require. We've talked in the closed board meeting about the next steps in funding rounds more broadly, but in essence within this capacity is potentially some unfunded OPEX commitments as we look forward. And the way we've addressed these is twofold really. The first is that we have accepted the liability for the hospital in the context that when we were doing it, we're existing in the only known then published environment, which is we will be given top-ups to bring us to break even. And although we expected things to change, at that point, that was the only context environment we could actually point to. And secondarily, we have gone back to our risk profile assessment, and as we know, we have always said that we are prepared to take a high commercial risk, and in that context think financial, in order to take a very low risk on the clinical outcomes for our patients. And that's really what all this capacity has been about. Even on the unfunded part, unfunded at this point, we have also sought as much assurance as we can through the executive out into the wider community to get agreement that this capacity is required and that we should be doing this. So within the context that we've had to operate in these unusual times, I think that the modern hospital has been able to derive the right and necessary assurance on these substantive projects. You're on mute.
Thank you. Thank you, Merrick. Any questions for Merrick on those minutes? I think that was an important statement that, you know, there's been a lot going on, but we have had assurance all the way through on these things. Okay, thank you, Merrick. Marcina, you back on? Do you want to ask your question again?
No, I can pick it up later. Can you hear me now?
Yeah, we can hear you fine now, Marcy.
Okay, good, thanks.
Jane?
I just wanted to say thank you to all involved in the Modern Healthcare Work Committee and all the executives, because they've done a tremendous amount of work over the last couple of months, and it's been a very changing field. So I think well done, you know, because it's been tough, really.
Thank you, Jane. Marcin, you're on with the People Committee annual report minutes first, and then the annual report.
Okay, so I'm just going to try and wrap them up, and then you can kind of ask questions because our last meeting was in July and we just had one last week. And so many things, as per all of our committees, has moved on quite a bit. And I think I would sum it up in that we feel that the people issues are, the risk around people issues is increasing. And that's really because we asked a lot of our staff during the pandemic. Then they had a break. Now we're asked a lot of them. We've got you heard from Emma. We've had the sickness. We've had the deaths. We've had just the change in offering model. It's quite difficult. But now we've got new issues emerging. There's a big risk around the EU. We had our first divisional report, which was estates, and appearance at our committee, and we really said what was the biggest issue worrying him on people. And it was around the EU and actually having the right amount of people and a solid understanding of what's coming down the track and managing that. And I think you need to get whilst the people recruitment and the vacancy factors come down, we still have an awful lot of issues around recruitment, around the churn, around planning for the numbers, because of course we're expanding our needs with all of the new units, and so it's a constant battle for Louise's team to constantly recruit. The government has given more money to support overseas nurses. I'd still like to see that money spent domestically, but that's a political issue. But we are still kind of treading. We're losing more than we're gaining, so we're in a net decreased position for the last 2 months, but we do have a trajectory. Louise's team have a trajectory to get us to where we need to be, maintaining that we can keep our people. So a lot's been happening, and I think the biggest focus for this month was the government's issued the people plan, and Surrey Heartlands has issued their people plan, and actually in your inboxes today you'll have received Surrey Heartlands people plan. Ours mirrors that, but the government set out 14 recommendations that need to be implemented by March. Louise has done a fantastic job gap analyzing that, setting out milestones, exactly how we're going to hit those. We're in a good position on most, but we've got issues and things that you would expect that we would be addressing, and the committee will continue to take assurance from Louise on her as she progresses with the implementation. And I thought it was one really interesting thing, and then I'll open it up for questions. What was when we asked, obviously the Estates Committee was our first divisional attendance. They have a high proportion of BAME staff. And he said, Chris said that actually the BAME staff feel very supported at the trust. And that was really, really good to hear that we achieved all the risk assessments, but they do feel supported by the trust. So everything that Louise and her team have been doing about health and well-being is excellent. So I think that's really positive. And I think there was one more, but so I think the one interesting insight we got from Chris was that the estates and facility teams don't see their primary objective as patient care. So there was kind of a disconnect, and it's how Chris addresses some of those issues. And an issue that we've been, as you know, putting a lot of pressure on Louise and her team on was around appraisals and mandatory training. And Chris acknowledged that they have really dropped on that, but he's got a plan to get it back in place. And we've asked Louise and her team to continue to do a dive and put issue in getting that resurrected, because that's a way of keeping your staff as well, is having a conversation, and not so much just about their performance, but about their health and well-being. And it's one of the requirements of the people plan. So we need to start talking to people about how they feel, just as how Emma said, she's getting a lot of support from Gemma and the team. We need to be communicating with all our people about how they're feeling. So Andy, I'm sorry, but I thought it was best if I tried to wrap it all up. The annual report is our requirement. We had a great attendance this year. We've moved a lot of things forward. I think it's an excellent committee. But I think that's good. And we've got a lot going on. So I'll take any questions on those two, and then we can move to the terms of reference, which is a quick change.
Thank you, Marcin. Thank you for that. Any comments, Louise, following that? No, you're happy?
No, I think Martin has said it all.
Okay. Any questions for Marcin on what she's... Jane?
I just wanted to echo some of Marcin's words and really thank the teams for all the work they've been doing around the wellbeing initiatives, because I think we did recognise quite early on that COVID is a long game, in that, one, we've got the disease, but two, we've got the staff getting tired, and the stress may not come out immediately when you're in the front line, but it actually can be months afterwards. And I think we've put that the officers have put a lot of different mechanisms of support in place, because not one thing suits on all. So I just wanted to just to say that that's really positive, and that I think we should continue with that and continue with force, because I think as people get tireder, they may well need that even more.
Yeah, agree.
Absolutely. Anything else for Marcin? No, and thank you for the annual report, Marcin. It's very clear. Thank you for that. Okay. So do you want to move on to the terms of reference? I think the amendments are very clear.
Yes, there's just 4, and it's really just clarification on our actual practice. So we have not calendar year, but we want to align it with the annual report, so you report attendance. So we moved to financial. Obviously, our people strategies are now informed by the people plan, because it's been published, and the Surrey Heartlands plan. So we just want to make that clear. And then I think we get to report on safe working, the Guardian and safe reporting, but we don't just get a quarterly, we get an annual. So it was really just clarifying and making it to reflect what we do in practice.
Okay, thank you. I think they're all very clear. Just on the number 12, approval, you've got approved by People Committee TBC. I'm presuming you have approved these.
Yes, that should say it was approved.
Okay. All right.
Sorry.
Because I wouldn't want to approve it.
I don't like people. Yeah. No, the People Committee approved it, right, Jane and Mike?
Okay. All right. So can I take this as approved, everybody? Speak now. Yep. Okay, so terms of reference are approved. Thank you, Marcin. And we're now going to move on. And Louise, you're going to take us through the annual equality report.
Yes, thank you, Chair. So people hopefully will have had an opportunity to read the document. A previous version in draft format has gone through our EDI steering group, through our network chairs, through the Trust Executive Committee at the beginning of September, and most recently through the People Committee last week. So I'm hoping that what you've got here is a final version which a lot of stakeholders have had the opportunity to input into. For the second year running, we've chosen to create a document in a format which we hope you will find more user-friendly. So certainly the infographics and the charts enable you to be able to navigate your way through the data in a reasonably easy way. But obviously it's not just the data, it's also the stories behind the data that I think are important. And so the addition that we've put into the annual report this year is very much trying to pull those stories out and give you a bit more of a flavour of the equality and inclusion issues within the organisation from a human perspective as well. We have quite a significant proportion of the workforce that come from a BAME background, 38%. So that's an increased number this year, which is as a result of our recruitment strategy to recruit overseas. And we've also been able to make some positive progress for that workforce around reducing the differential between our BAME colleagues and our white colleagues going through the disciplinary process. There's quite a lot of detail in the beginning of the report around the work that we've been doing to improve our people practices and to try to take an approach to issues when things don't go right, to learn from those issues and to try to create this sort of just culture feeling rather than going straight into a formal investigatory process. Having said that, there are some times when that's necessary. So again, what we've attempted to do is to make sure that the infrastructure and the support that wraps around that is taking into consideration the impact that this has on people. And so I'm really pleased that we've been able to reduce the difference between different groups and issues in relation to disciplinary. We've been very active with the networks this year, and obviously it goes without saying that the disproportionate impact of COVID on our BAME communities, and at the same time the matters that were being raised around Black Lives Matters in society has meant that it's gained kind of significant momentum in the organisation around the fact that we do have discrimination and we do have inequalities, and what we might want to do as a community, as a workforce, to try and address some of those matters. So our BAME and LGBTQ+ networks have gained a lot more interest this year. I think the virtual nature of Teams means that actually people can access those meetings much easier. So it's been a really big positive in terms of engaging more people. And as I said, socialisation of talking about things like race and issues has meant that people are much more engaged and willing to participate. And obviously the Surrey Heartland system level resources have also increased and enables us to share their best practice and their resources. I suppose the issues that we still face are that there's still a disproportionate representation of BAME colleagues within the more junior ranks of the organisation. One of the people plan targets is that we will have a much more proportionate representation throughout all of our grades. And so this is something that will require some focus. Matthew and Andrea and I and the teams have already started to think about the additional support to our nursing colleagues, as we have quite a high proportion of those colleagues from a Black and minority ethnic group, but that remain within our sort of band 5, band 6 staff groups and struggle to progress to the more senior grades. So a focus on career conversations, education, opportunities, and encouraging people to apply for promotion will be something that will be a big focus for us going forward. So I'll pause there because I think I've given you the key headlines. I guess the point for me is that that we are moving this agenda forward, but there is still much more to do. There are some elements of good practice, but we need to make sure that that isn't sort of the exception, but it's actually that's what happens all the time. We also recognise the fact that in order to really drive the diversity and inclusion agenda, we will need to add some additional resources into our system, because at the moment it's pretty much something that we do as an add-on to our full-time jobs, and that isn't going to mean that we're successful in really trying to create a fair and inclusive culture across the whole organisation. So I'll pause there, Andy. Thank you.
Thank you for that, Louise. Marcin?
I just wanted to say that this report came to the People Committee. We welcomed the report. We thought the layout was excellent. It's a very good read and a clear read. And I think if I just take the Ned's comments, the three big things we picked up on is a concern for Louise and her team about the big agenda that this is and whether we have the expertise necessary, and that she may need the resource to support the agenda. We also picked up on the issues around recruitment to really make sure there is no bias in our recruitment and our promotion, and that we supported her that next year's report really should start to address the pay gap issues around the BAME staff. So 3 recommendations from the People Committee, but we endorsed this report and we thought it was outstanding, and we thank Louise for it. Thank you.
Thank you, Marcin. David?
Yeah, I'd like to echo Marcin's views. I mean, there's such a tremendous amount of data in this report, but it doesn't. I think we do need a lot of support to look at this, because actually there is lots of detail in here which we may be pulling out. And obviously, I gravitate to the medical workforce data, which is interesting and different from lots of the other groups of data there, and that is a mixture of, so the foundation year is people who've gone to university predominantly in this country who've come into that, and that's quite a startling change in the demographic compared to the country, actually. And then the demographic as you move through these different grades, and some of those are because we've recruited from abroad, which is changing those differences. And I think that one of the conclusions from here, particularly in the medical workforce, is to try and understand how the BAME community is represented in the senior medical leadership roles. And I think the other big thing in medicine is the gender gap, the gender split between those groups. And I just would bring up that the really differences between, say, the nursing workforce and the medical workforce, and we just need to look at those, because one of the things that I've tried to highlight is the number of nurses who are male is about 20%. And actually we need to address that as well. We need to understand why that is, and that's about recruitment, and that's about branding, and that's about demonstrating the great career opportunities that are in these groups. So I think it's a fantastic report, but I think Marcin's right. We do need some expertise in helping us understand this detail in more detail, to help direct how heterogeneous the response is within the organisation.
Okay, thank you, David. Andrew?
Yes, I'd agree with what David saying. My colleagues and I have spent our time in the middle of a global community for about 35 years. So we've come across these issues many, many times before, with real people, with real names and addresses. And people like me worry that the present discussion that's happening nationally around some of this is pretty ill-informed, actually, about the practical consequences and the links between the words and the practical outcomes. It's very interesting that the new CEO of John Lewis, who is black, is not going to have the BAME policy references within her organisation, because she thinks they're very condescending and fail to grasp the real issues. Very interesting to listen to her as a black person about that. Had a similar conversation with some Muslim entrepreneurs in Leicester, where we're in the middle of a major six-acre development. There were some very successful people who were referring to some of the naivety in the system of how it looks from their point of view. And just final thought about it, we first came across this 20 odd years ago of the unintended consequences of a lot of this intellectual rhetoric coming out of our universities, when a group of a black housing association had been formed to develop some housing locally for black families, which caused a bit of a riot on the estate, because white families living in tenement blocks thought, well, why are these families who are coming in from Somalia going to get all the best houses with gardens? I then began to raise questions about this and said, no, you need to build mixed communities. It is not a good idea to build these ghettos. We were ignored. We were accused of racism at the time. This then happened. The poor Somali families who came got a lot of aggro from local people. It wasn't their fault. Then one of our doctors, because of course these people came to our surgery, began to say to me, Andrew, why have we created a mentally ill street down the road? I said, what do you mean? He said, these people have come from Somalia. Some terrible war has been going on in Somalia for a very long time. You have 12-year-olds who watch their father have their arms amputated, and horrific stuff. They have really difficult mental illness problems, and we've all put them together in the street. Wouldn't it have been better to mix them up with EastEnders and Rita Jarman down the road and all the rest of it? And actually, we then, our Muslim communities actually from Bangladesh, intervened in that street and began to build relationships in a community. The only reason I just share these little stories with you is I think there is a national dialogue and a lot of confusion in this space. And I would suggest that the hospital would be really wise, because I think it's really important, because the unintended consequences, in my experience, is usually paid by the black community, in our case, the Bengali or Somali community, by a lot of naivety in this space. So it's a really rich space. It's a really good you're having the conversation, but to hear different views and get into the detail, and I know Louise is really concerned about that, it's really important.
Thank you, Andrew. That's very good. And that Somali story, which obviously I heard yesterday as well on the webinar, is a very powerful one, isn't it? I'll let Louise respond before we go to Mike.
I mean, I think what you're illustrating, Andrew, is that we are just at the very start of our journey here. And, you know, David and Marcin have both referenced the need for us to make sure that we have experts in this field that are advising us, but also supporting us. And, you know, actually what I found with our BAME network is that they've managed to attract the interest of a huge number of people in the organisation, you know, a lot of whom are white staff who want to be part of a conversation about how do we make sure that just because you've got a different background, that you've got a different colour skin, that you've got different sexuality, that you're not treated differently. And so I think you know, our network is making a very positive contribution, but we are amateurs when it comes to this agenda, and we need to find people to help us with it.
I mean, just one final thing I'd say, it's very interesting talking to Sean on that ward, and his description to me a couple of weeks ago of the black nurse, his response to him and the crisis, and the insight from her coming from Africa, actually, not coming from London. Are sort of interesting. Those details get really interesting, but is our society even noticing that? It's not to do with this hospital, it's to do with where we're looking and how do we see things. It's sort of interesting.
It's the detail, isn't it? And the listening to people rather than standing on the sidelines and pontificating. Mike.
Yeah, hi. So maybe my question has been sort of slightly derailed by this conversation. A majority of it I absolutely agree with. But just to make one comment, that I think the report is fantastic. The use of infographics, I think, is wonderful, and I think it's something that we should look to use in our our accounts generally, particularly for the general public to access the information. The point I was going to make about the early bit in the discussion is that I think Ashford and St Peter's, under the People's Committee, and guided by Louise, but under my chairmanship, and Marcin has continued it, has been really interested and exercised by this whole idea and concept of equality. I think, in a sense, the NHS has caught up with us, and the recent document that the chairman identified and circulated was very helpful. And I think it made one point, didn't it, which, you know, I don't mean to be controversial in the discussion, but is that, first of all, you need to recognise and acknowledge there's a problem. And I think, you know, that is true. What the solution is and where it comes from is a whole level of different discussion, which David has clearly articulated into, you know, we need to scratch at the detail, but we need to, and have done, recognise that there is a problem.
Yeah, thank you, Mike. Mike, and you'll see a quote from me in there as well. I think my point was around equality of opportunity, and I really welcome the progress that we're making, but we are at the beginning, as everybody said. I was worried about the equality of opportunity for disabled people, actually, and the little fact there that sort of said very low percentage coming forward say they're disabled, and then in the staff surveys far more, which says to me that people believe that they won't get the job if they put down their health conditions mainly, or mental health conditions even. And so I think there's a work to be done on, you know, how we attract people with disabilities, and portray ourselves and are true to that in terms of employing people.
And again, there's a story in relation to the benefits of people declaring what their health conditions are, so that we can accurately reflect that in terms of our data and in terms of the activity that we want to do. And so we are doing our first port of call with that, Andy, is an awareness raising campaign, which will be starting soon.
And certainly, you know, given the prevalence out there in the community, you know, mental health, you know, taking on people that do have, you know, mental health issues, but are probably absolutely fine to do their work, I think would be something that I would urge anyway. Keith.
I'd just like to echo the comments that other colleagues have made about how helpful the infographics are, and I was particularly struck by the overview of the workforce profile and the sheer volume of applications and even shortlisted applicants that the workforce colleagues have worked through in the course of a year to arrive at less than 400 people being appointed. So for me, that really brought to life the scale of the operation. And so Louise, you know, just reflect to you and all of your departments, you know, the board's appreciation of the care and the attention and the sheer scale of the work you're doing.
Thank you. No, thanks. So thank you. It's a very good report. Thank you very much for that. Okay. So now Neil isn't here to present the Strategic Change Committee annual report. Tom, can you step in?
Yes, I can do that. I think it's obviously already been presented to the Strategic Change Committee, I'll take the paper as read. The report summarises essentially the business of the committee through the year, with the attendance record provided, the terms of reference attached to the end of the report, the detail of the regular items that the committee has considered, and then some specific reports that were provided as requested, and the overall objective of the committee is clearly stated in the report. And then finally, it runs through the BAF risks that have been allocated to the committee for oversight, and that really focus the work of the committee and the development of KPIs to support them.
Okay, thank you, Tom. So anybody got any questions on that or the attached terms of reference? We're all on that committee anyway, so we've all seen these before. Okay, all right. Thank you. We'll move on then, and we move on now to the BAF, David.
You're muted, David.
Sorry, I think I was unmuted and I'm muting myself there.
What you were saying was fascinating, though, David.
It was. I was really pleased with it. But it just identifies the 16 risks in the BAF. As you can see, that we take reports from all the sub-goal committees who review their BAF risks, and we adjust that. There have been no adjustments to it. I think that the big piece of work going forward at the moment is to make sure we have all the sub-board committees defining their key performance indicators, and I think that makes it much easier then to assess whether we are dealing with these risks or whether we're just tolerating them over a period of time. So I think that's where the focus is now, is to make sure that we are putting in proper mitigation within these risks, that we're not just tolerating them, and actually we're tracking the performance against these risks, and that's the key performance indicators. So I know Marcin will say we've got a long way to go, which I agree with her, but I think we've started moving there, and I think And I think, just the board meeting, we've been talking about the BAF quite a lot through it. Everyone's representative from the committee, so I think if there's specific risks that people want to raise some issues with, I think that we can ask the sub-board committee to answer those.
Okay, thank you, David. Marcin.
David, I was going to say we're doing extremely well, and I'm pleased. I hope, Sal, we're finally getting going on this. It's sticking. It's a conversation we're now very au fait with. I'm very pleased about how much progress we've made. There was one thing you weren't right about, though. Sorry, darling.
Just one.
Yeah, just one. 4.2, the People Committee changed the risk to red. And I don't know why it's not reflected, but we felt, as I said in my intro, that all of the people issues are high risk at this point. But I agree with you, and I just would like to congratulate everybody that we're really getting this to stick, and the KPIs is our next stage. So thank you.
Thank you, Marcin, and we'll get the team to change that, of course, and we've now got you on recording as well, saying that. So that's good. Anything else on the BAF from anybody? Okay. Any other business? Sal, I think you've got some business for us.
Yes, it was just a point of note, Andy, regarding the 2021-22 scheduled committee dates.
You're distorting, Sal.
Turn my camera off to see if does that help.
Keep talking. No, it's the sound.
I see. Okay. Shall I continue?
As a Dalek.
Yeah.
It's fine. I'll put a note round.
Okay. All right. We'll do a note. Yeah. The wonderful world of Microsoft Teams. If Bill Gates were here, he'd probably describe it as a feature. Okay, so anybody else got any other business? No? Okay. Marcin, your hand's still up. Are you?
Andy, if this is Mike's last board, should we not say anything?
It isn't his last board.
Oh, okay.
I think
Take
we've got.
that back. I'll go back on mute.
Let me just check that. Because I might be wrong, because I thought there was a board meeting end of October, but there probably isn't, is there? So you're quite right, Marcin. Sorry, my brain's a bit addled. So yes,
it is, however, my last board meeting, and I just want to thank the whole board, how welcoming you've been. It's been a real eye-opener to see how much work behind the scenes goes on in checking, rechecking, re-evaluating all the decisions that clinical teams make, and that's reflected by the executive team. So I do have absolute assurance that as a board you are doing a fantastic job, and that is great to see. So thank you all for allowing me some insight, if nothing else.
And thank you, and Zach, as I said earlier, thank you for stepping in.
That's all right.
And you've done a fantastic job stepping in, and I think as David and I reflected the other day, the great thing about you is you get things done. You don't just talk about things, you actually get things done, and I want to thank you for that. It's been a pleasure working with you at this level. And Mike, it may well be your last board meeting, because it's all subject to the Council of Governors and recruitment checks for your replacement. Not that anybody could replace you, of course, but I would like to thank you for all your work over so many years for Ashford and St Peters, not just the non-executive side, but obviously you've been associated with us for a very long time. But for me, over the last 3 years, I want to say thank you. You've been a pleasure to work with, and your insight and your incisive questioning has been really, really helpful to us, both on the quality committee, but actually on the board as well. So on behalf of us all, I want to thank you sincerely for all you've done, and wish you all the best at our next door neighbours.
Thank you, Chairman. Thank you. It's been an absolute pleasure. 26 years or something now in total. I've enjoyed every moment of it. I'm sad to leave, but it's time. And I will be close by, and I've got strong links with the board, and hopefully we can continue to talk, and I can facilitate some of those inter-organisational discussions as we move forward. But thank you, everybody. I've enjoyed working with everybody. Thank you very much.
Thank you.
Mike. Thank you.
And the sadness is that, you know, we can't have a dinner to say goodbye just now, but you know, we'll put that in the schedule somewhere.
Yeah,
for a post-COVID era. Any other business? Keith, you got your hand up?
Yes, just to say that looking ahead to this afternoon's masterclass, I haven't received, I don't know whether colleagues have, an appropriate Microsoft Teams sort of link to join that. So if that could be arranged before 2 o'clock.
Yep, thank you. How very southern of you. It was a master class. Very good.
And to say I'll probably be about half an hour late to that meeting, I'm afraid.
Okay, thank you. Almost seen your hands down now. Okay, so we've got some questions from the public, Liz, I think. Are you there, Liz?
Yes, we do. Sorry. Yes. Let me just get them up.
Can you share them?
I don't know whether I can share them.
They looked, certainly the ones I saw looked fairly easy to answer on.
Yes, I'm just going to. Okay.
If it's difficult, Liz, just read them out.
I'm going to read them, if that's all right.
Yep. And so who's this from?
So this is from Rosemary Moore.
Okay, we know Rosemary, yes.
Yeah, and the first one is about the physio project with Bourne River in Chertsey. Has this restarted, as this was talked about at the May board meeting?
So, David, do you want to answer that one?
Well, it never stopped completely because the team carried on doing virtual appointments during this time, so they stayed in contact with them. I think it has opened to a certain extent, but it's not where it was to begin with. Andrew, do you know that? Do you know where they are?
Yes, they're starting to gradually open it back up again.
Yeah,
absolutely. Yeah, they're not as pre-COVID, but they're heading towards that.
Tom, did you want to say something?
Well, only to say, yeah, what Andrew's just said, and also to say that we're pretty close now to landing them opening up in Woking Leisure Centre as well. So that model is expanding, which is really good news.
Okay, Merrick.
Yes, just to say, Andy, when you I think you were away on holiday, I went there with our local MP. That must have been about 6 weeks or so ago, and they took us through what they were doing. We talked to some patients, is that the right word for physio? I don't know. Online about how it was going, and they were achieving a lot actually, even during the lockdown part, remotely working, and we saw that, so that was good to see.
Okay, yes, of course you went with Dr. Ben Spencer, didn't you? Yeah, I'd forgotten about that. James?
Yeah, so it's restarted to the level of, you know, what all of our therapy services have started to. So there's been no difference on the Ashford site. They've managed to do a lot by Attend Anywhere. They were the pioneers of Attend Anywhere. So regardless of what site they're coming from, a big proportion of what we were doing was virtual, as well as the sort of outreach in the leisure centre. So yeah, it's restarting as with all of our therapy services.
Okay, I think that's a good comprehensive answer for her. Any other questions, Liz?
Yes, the interface meeting with Surrey and Borders Mental Health Trust and the 5 general hospitals in Surrey I learnt of these at the 18th of August committee meeting of Surrey and Borders Focus. Sharon Gregory, Divisional Director for Older People and Specialist Services, said this is ongoing. Who is responsible for these meetings at our trust? Okay, so who goes to the Surrey and Borders, that meeting from our trust is the question. Yeah. Who knows the answer? And it stands for Forum of Carers and Users of Services. I presume that we do have somebody that goes. Do we know?
I'm not aware, Andrew, are you?
No, I'm not actually.
No,
so we need to look into that.
Okay,
that is not a forum I'm aware of.
Okay, so sounds like it was said at the committee meeting that the hospitals are invited or involved. So if we could just find out who that is and let Rosemary know, that would be through Liz and Liz there. Okay, and I think there was a third one, Liz, was there? Yeah, that was about Lord Andrew Mawson, Special Advisor to the Board. Rosemary asked, I see that he's in attendance at the board meetings. Will he be invited to speak at the meetings? Oh, I think we've answered that one today, haven't we? We have. Andrew is always welcome to speak at the meetings and has done so today. So we've answered it practically. Were there any other questions from anybody else? No, that's all that we've received. Okay, so that's fine. So just one question to check on there. So reflection on this meeting, everybody, any thoughts?
I thought it was quite a tight meeting, actually. We covered a lot of ground. Some of it were needed in detail, but overall a tight meeting. So thank you.
Okay, yeah. That was my impression was, it was, the big one for me that came out in spades was the work the committees have been doing. And I think it, particularly today, all the people, the Modern Healthcare and the Quality Committee and the assurance that they are providing through the non-executive leads back to the board. And I think that came out really strongly today. And I absolutely welcome that, because we trust our colleagues to do the detailed assurance at the committee level that then comes up to the board for more general oversight and assurance. So thank you to all of you who are involved in all those subcommittees, because I think they're really doing their assurance job. We didn't get a chance to talk too much about digital today and strategic change, but the other three certainly came out very strongly. Okay, so the date of the next meeting is the 26th of November. It will be via Teams again. I want to thank you for your attention, although it's been quite a long meeting. And I think Tom, we're on again at 2, is that right?
That's right, Andy. Yeah, and I've just put a note in the comments chat box there just to say there is an invitation that should be in people's diaries. It is called Hold for Board Masterclass, but it's got the Teams link in there. So hopefully, Keith, you've got that. But yes, 2 o'clock, and we'll be joined obviously by Jack Wagstaff and a couple of other colleagues for that conversation.
And if we really say, thank you for that. Did you just say again where it is, Tom?
It should be in your Outlook calendar.
I've just resent it.
Okay, because for some reason the calendar within Teams doesn't. Mine is empty. I don't know why that is, but I get the chat and various things, but I don't see anything in the calendar within Teams. It'll be
the calendar in your NHS.net account.
Yeah.
Okay, I'll have a look there then. Yes.
Okay, David.
I was just going to say thank you to Sue for spending the day with us.
Yes.
And I hope she's found it informative.
I was going to ask Sue if you've got any kind of immediate reflections for us.
It's a difficult one to ask me that, putting me on the spot. But
sorry.
No, not at all. I just want to thank
that's your job.
Observing the board meeting twice a year is required of me by CQC, but I always find it incredibly valuable to understand the challenges you're facing. But my main reason for being here is also to assess how you gain your assurance, and that's been really positive today. So I think I can safely say that. And also I have regular engagement calls with Andrea and the team. they're always very open, they're very constructive. So when I come to the board, there's not too many surprises, which is also good. So I'd just like to sort of say thank you for that as well. So it's been incredibly helpful. It's always good to attend. Thank you.
Thank you, and it's always good to see you, Sue. Thank you. I've got some final hands here. We've got James.
Mine was an old hand, sorry, Andy.
You're a bit of an old hand, okay. Andrew?
Just got to say, I think what I enjoy about these meetings, it's great you have people like Emma and others from the real coalface and the micro speaking to the macro. It's such a great engagement, and it's so rare in my experience that happens. And I'm just starting, as you know, to engage with the ICS and the big systems around Surrey at the moment. And it's a methodology, Andy. You might just start sharing with other people, because it's such a great thing to be happening both ways, actually. Because really understanding real assurance and really getting into the devil and the detail needs a really good conversation between the micro and those at the front edge and the people responsible for the systems. It's a really important thing, and it's always a reassuring thing to me when I sit as an observer on these board meetings. So it's very good.
Thank you, Andrew.
More widely. Yeah.
And certainly I can assure you that exactly the same format has been I was going to say imposed, that's wrong, has been introduced to CSH Surrey. So we are sharing it. Thank you very much, and we'll reconvene at 2 for those of us who are going to join the masterclass. Thanks. Bye.
Thank you.
Thank you. Bye.
Bye, Sue.
Bye.
Right.